I'm hoping you guys can see the screen. I'm hoping you can see my two co-authors. Let me get a laser pointer going here. Here we go. So this is, can you see the laser pointer? This is Mark. Yeah. This is Mark Anderson.
As long as it is peaceful, as long as it is not harmful, it works for us.
Yeah, well, yeah, you don't want to shine it in someone's eyes. So this is Mark Anderson. This is Kerwin Charles. We've worked on a lot of projects together, and we have a number of ongoing projects. So let me just start with that as an introduction. Mark is at Montana State. Kerwin is at Yale. All right. So, like I said, there's a lot of institutional detail here. The focus of the paper is Southern hospitals, specifically hospitals in the Deep South, and I'll define that in a moment. So before the Civil Rights Movement, so say before the mid-1960s, before 1966, hospitals in the South were racially segregated. Hospitals, without exception, in the Deep South were racially segregated. And what that meant is if you were a Black patient, you really had only two choices. You could go to a Black hospital, but Black hospitals focused on providing care to Black patients, but they're understaffed and they lacked the latest medical technology. Or if you were a Black patient, you could go to a white-run hospital, right? So some white-run hospitals were called biracial. They accepted Black patients, but the Black patients were physically separated from their white patients, and they absolutely did not receive the same level of care, all right? And when the Civil Rights Movement began, one of its main objectives, its key objective, was ending this system of racial discrimination in the provision of healthcare. All right, to give you a sense of sort of what this looked like in practice, there's surprisingly few photos of this, but this is a photo from the University Hospital at the University of Alabama, and it's obstetrics ward for Blacks. And you can see there's no, they're not trying to hide the fact that Blacks were segregated. It's cut off, but this says colored obstetrics ward. And you can see that it's crowded. Everyone is in the same room. Blacks are not receiving the same care as whites. Black mothers in particular are not receiving the same care as whites. All right. Most hospitals in the South remained racially segregated until the spring of 1966. And in the spring of 1966, the Johnson administration, the federal government, said, look, if you're going to receive Medicare funding, you have to be in compliance with Title VI of the Civil Rights Act. And Title VI of the Civil Rights Act said it provided a series of guidelines, and it prohibited racial discrimination in the provision of healthcare. And so in March of 1966, the federal government launched a campaign to ensure compliance with Title VI, and they sent agents. So there was a newly created Office of Equal Health Opportunity, and federal agents fanned out across the country. It was a massive effort, and they certified more than 7,000 hospitals as Title VI compliant. And if a hospital was certified as Title VI compliant, that means that it didn't discriminate against blacks. It was desegregated, right? But so by November of 66, almost every hospital in the country is certified as Title VI compliant, but 214 hospitals in the South decided to forego all federal funding. So not only Medicare funding, but also Medicaid funding, all federal funding. And if a hospital is foregoing funding, if they remain non-compliant, well, that means exactly that they're non-compliant, they're still practicing segregation. And this is where our identifying variation is going to come from. It's these 214 holdout hospitals. Oh, and these hospitals held out for years, at least some of them did. So as late as 1973, there are still hospitals in the South that are refusing federal funds and in order to remain segregated. All right.
Dan, can I make a couple of quick qualifications?
Please.
One, is there an illustration of the lack of expertise in the segregated hospitals, which springs up to the mind of any American who was say in their teenage or later in 66, for example, surgery or treating polio? Are there evident causes?
Yeah, so
which you can have in, which I don't know, they've been reported by every journalist, photographer, for example, which will make a compelling case, which every American would say, hey, you know, this is really what the effect of segregating, at least the anecdotal one.
Yeah, there's a couple of things. It's not at all clear that the average American, even in the South, would remember that. Certainly the average white American in the South would even remember that hospitals were segregated up until 1966. So this is actually, this doesn't receive, the system of segregation in healthcare doesn't receive a lot of attention these days. So it's not widely known. But to give you a sense of how rigid the system was, there's plenty of anecdotal evidence, but the I think the most poignant stories are stories of Black mothers in the middle of a difficult pregnancy, arriving at a hospital, a white-only hospital. You know, they are in a medical emergency, and they are literally, and this happened repeatedly, turned down, not allowed to receive care at the hospital. They're told they have to go to a Black hospital or a biracial hospital, and they end up dying because they've been turned away. So a white-only hospital, if a woman, a mother, in the middle of a medical emergency arrives, that's not a good enough reason to receive care. They'll be turned down and told to go to a Black-only or a biracial hospital. So the system is that rigid that there's no exceptions. There's no such thing as a medical emergency. If you're Black, you cannot receive care at a white-only hospital. And there's no denying the fact that Black hospitals were horribly understaffed. They didn't have the latest technology. If you were in a medical emergency, you absolutely wanted to go to a white hospital. Does that make sense?
Super. Thanks so much for clarifying.
Okay. I'll give you some more details as we go on, okay? More institutional details as we go on. Okay. Historians have called the federal campaign to desegregate hospitals as a powerful force for equal treatment and among the most important civil rights achievements in US history, right? But there's actually, it's quite astounding. If you look at the literature, there's only one paper out there that examines the effect of the federal campaign to desegregate hospitals. And the paper that I'm talking about is this famous paper by Almond et al. And Almond et al. Focused on Mississippi, so one state in the Deep South, right? And they looked at post-neonatal mortality rates for Blacks versus whites. And post-neonatal mortality is just the infants between 1 month old and 11, the first year of life, excluding infants in the first 30 days of life, okay? So they're looking at the post-neonatal mortality rate in Mississippi. And what these guys found is that the federal campaign to desegregate hospitals saved tens of thousands of lives, and in fact, contributed substantially to the narrowing of the national Black-white post-neonatal mortality gap. And so this paper is, obviously these guys are superstars, right? This paper was never published. It is to this day a working paper. The story goes like this. It was actually accepted for publication at the American Economic Review. They just had minor revisions. What's the term? Accepted pending minor revisions. And the authors got into an argument. And no one knows what they argued about. But it's one of those working papers that everyone knows. It's incredibly famous, but it's never been published. David Card actually described it as the best piece of forensic work he could think of. And, you know, if David Card thinks that it's the best piece of forensic econometrics that he can think of, that's high praise. All right. So we're going to adopt their identification strategy. And we're interested in the question that they're trying to answer. But, and this is important, I need to really emphasize this, Almond et al. Did not control for year fixed effects in their regressions. So they did not account for the steep trend in Black neonatal mortality during this period. And they were very upfront about it. They just said, hey, we don't have enough variation in Medicare certification dates to control for year fixed effects. So what we're going to do, our contribution, let me show you that it's important to control for year fixed effects. There's a strong secular trend in infant mortality. This is for the whole of the Deep South. There's a strong secular trend in post-neonatal mortality. This is Black, this is white. So it's a downward trend during this period. And then this is again for the whole of the Deep South. And then here it is for each state in the Deep South broken out. So we've got Alabama, Louisiana, South Carolina, Georgia, and Mississippi. Now remember, Almond et al. Were just interested in Mississippi, but the trend for Mississippi looks very similar to the trend in the other states in the Deep South, okay? So they're not controlling for this secular trend. What we're able to do is, because we're going to look at data from 5 states, not just Mississippi. So we're going to look at data from Alabama, Georgia, Louisiana, Mississippi, and South Carolina. We're going to leverage more cross-county variation in Medicare certification dates. So remember, the date in which a hospital is certified is the date in which it desegregates. And because we've got more cross-county variation in these dates, we're going to be able to distinguish between the effects of hospital desegregation and the secular trends. Now, Almond et al. Found that, or they concluded that hospital desegregation had this huge effect on the Black-white infant mortality gap. We find exactly the opposite. So I'm going to show you that becoming Medicare eligible or having access to a Medicare eligible hospital, an ostensibly desegregated hospital, had absolutely no effect on the Black infant mortality rate in the short run. So our results are completely the opposite of Almond et al., right? Specifically, what I'm going to show you is having access to a certified hospital is actually associated with an increase, now very small and statistically insignificant, but nevertheless a positive effect on Black infant mortality. So Black infant deaths per 1,000 births, right? And even though this estimate is not statistically significant, it's precise enough to clearly reject the hypothesis that the federal campaign contributed to the narrowing of the Black-white infant mortality gap. And so that's where we're headed. The bottom line for this study is very different from the bottom line of Almond et al. Almond et al., you come away sort of hopeful that the federal government, that policy can have this effect. But our results suggest that simply certifying a hospital as desegregated wasn't enough. It wasn't enough to ensure that Black infants experienced the same health outcomes as their white counterparts. It's really a sort of disheartening story. At least in the short run, it seems like this campaign was not a success. In fact, it seems like this campaign was an utter failure. All right, so that's where we're headed. Before I really get into the institutional weeds, do you guys have any questions? Shall I pause here for a moment?
May I have a quick
question?
Sorry, Daniel, a question that may be not relevant. So if it is not relevant, please forget it.
No.
Is there any kind of relationship between health and education of the Blacks? Do the same problems that arise here arise also on the education side?
Yeah, so let me rephrase your question, okay? So this is a period during which education of Blacks in the South is rising. There's also other health interventions that are going on, and income of Black workers is rising. And what's more is there's a lot of evidence, or Owen Thompson has provided evidence, that there's selective fertility going on. So there's lots of other stuff going on at the same time that could explain why it is that Black infant mortality is falling as dramatically as it is, right? So the way I interpret your question is, what else could explain the trends that I've shown you? There's lots of other things that could explain those trends.
Thank you.
What I thought I heard another question.
No, I don't think so.
My quick point I had is the desegregation was, if I got it correctly, came with funding attached.
No. Yes. The incentive to desegregate
Desegregation of hospitals.
Yeah. So if a hospital desegregated, that meant that they were certified to receive Medicare funding. And Medicare very quickly, so Medicare was launched in the first date was July 1st, 1966. So it was launched in 1966. And it very quickly became an important source of funding for hospitals, especially in the South. So if you forewent Medicare funding, your hospital, as I shall show you, your hospital became financially unviable. So the pressure was financial, yes.
Are you going to tell us about the deployment of such funding, the different choices which a desegregated hospital could do, and whether and how this can partly explain your non-significant result?
So we don't have a lot of information on funding. We just know when the hospital became certified and when it was allowed to accept the funding. There's anecdotal evidence that the hospitals that refused the funding were under tremendous financial pressure to take the funding. I'm trying to remember the average. Forgive me, it's on the order of 50% of revenue to hospitals during this period was coming from Medicare. It's a lot of money that they were foregoing. But as I get into the details, maybe there'll be a chance to ask these questions. I'll try to give you a sense of how this worked. Okay.
Super. Thanks.
Okay. I'm not going to have as much financial detail as you want. But here we go. So the Civil Rights Act passed in 1965, and Title VI of the Civil Rights Act bans the allocation of federal funds to hospitals, in fact, to any entity that discriminates on the basis of race. But through 1965, compliance was entirely voluntary. If a hospital didn't comply with Title VI of the Civil Rights Act, there was really no penalty. And not surprisingly, hospitals in the Deep South, almost without exception, did not comply. They continued to engage in segregation and discrimination. But in the spring of '66, the Johnson administration says, all right, look, this is it. We're about to launch the Medicare program. The start date was July 1st, 1966. And they required that if a hospital is going to participate in Medicare, it has to be certified as compliant. And certification was determined by this newly created Office of Equal Health Opportunity, so the OEHO. And the OEHO trained hundreds of investigators. And these investigators would go to physically travel to every single hospital in the South. And they would work with civil rights activists and Black hospital workers, and they would inspect the hospitals, and if there were discriminatory practices, they would force the hospital to correct these practices in order to become certified. Right? And this was just an extraordinary effort. Over the course of 3 or 4 months, they visited every single hospital in the South, and almost every hospital, the exception was 214 hospitals, almost every hospital was eventually certified as compliant. I don't want to give you a sense that the process of certification was smooth or that it was always smooth. Sometimes the process of certification was met with fierce resistance. So there's stories of OEHO investigators having their tires slashed. There's stories of death threats. And in fact, evidence that it didn't always go smoothly comes from the fact that 214 hospitals just said, look, we don't want the money, we're not going to desegregate. What's more is there's evidence that hospitals that even after they were certified, the hospitals would nevertheless go back to completely flouting the Title VI guidelines. So this is a This is from testimony in front of the U.S. Congress of Jeffrey Merrill, and he worked for the American Public Health Association. So they did a study of hospitals in Mississippi, and what they found was so they were inspecting these hospitals in Mississippi, and the hospital would get warning that they were about to visit, and he pointed out that hospital beds are on wheels, and so it was a very easy thing for the hospital to wheel everyone around before the visit, make it look like the hospital was actually integrated when in fact it was not. And then a couple of days afterwards, they would just wheel everyone back to their respective places, their respective wards. So I don't want you to get this, I don't want you to think that this whole process was smooth. It certainly was not. All right, I'm looking at my watch, and I need to go a little faster, so forgive me. I'm going to try to get through the institutional detail a little faster here. In 1972, the GAO, so the Government Accounting Office, tried to do an assessment of whether certification, whether desegregation was working. And they did a study of 4 cities, 2 of which were in the Deep South, and then Detroit and Los Angeles. And what the study found was in these 4 cities, the desegregation campaign had really eliminated overt discrimination. So it was no longer acceptable to segregate blacks into separate wards, nor was it acceptable to turn away blacks if they showed up with a medical emergency. But the GAO investigators nevertheless said there are, it's not like there's no, it's not like the federal campaign eliminated discrimination. There were more subtle forms of discrimination. Most black patients, most minority patients were still receiving health care at just a handful of public hospitals. And private hospitals treated very few black patients, even after the desegregation campaign, right? And one of the ways that private hospitals kept black patients out was that they just denied staff privileges to black physicians. And so if you don't hire and don't employ black physicians, you're effectively barring their patients. Just as an example to show you, even after, so this is 1971, 1972, even after the desegregation campaign, there were 15 hospitals in Atlanta, right? Every single one of these hospitals was Medicare certified, so it was ostensibly desegregated. But almost 60% of black patients in Atlanta were being served by the one public hospital, Grady Hospital, right? And if you think about it, if you're a black patient and you need treatment, you need medical care, you might be understandably reluctant to go to a hospital that has been treating you, discriminating against you for generations, right? So just because a hospital is certified doesn't mean that black patients are going to want to receive care at that hospital. And there's a lot of anecdotal evidence that black patients were, I use the word here, reluctant, but they were genuinely scared to go to white hospitals that were formerly white only. They were afraid they were going to get turned away. They were afraid that they weren't going to receive the same sort of care as black, rather as white patients received. All right. You guys wanted, I'm looking at my watch, I'm running out of time. So you wanted anecdotal evidence. This is a newspaper article from 1971 this is a certified hospital. So this hospital is ostensibly desegregated, and the hospital nonetheless, it didn't quite implement a policy requiring Black Medicare patients to give a $250 deposit before receiving care. Now, in 1971, this is a hospital in Mississippi. In Mississippi, requiring a $250 deposit for Blacks is, that was beyond the means of most Black patients. And I want you to understand how discriminatory this was. The plan would not require whites to make deposits because most could afford to pay the balance of their hospital debts, said the administrator who proposed this plan. All right. There's more anecdotal evidence that even after desegregation, so this is a hospital maternity ward in Memphis, Tennessee. This is photos taken in 1970 after the hospital was certified, but you can tell this very much looks like a segregated maternity ward. Crowded, all the patients are Black. All right. So I've got about, I'm doing okay. I've got about a half hour to go through, the regression results, the reason you guys are here. I can do it in about a half hour. I'm going to have to talk quickly. All right. So the question now, let's get specifically to the research question. Did the federal campaign to desegregate Southern hospitals, which was launched here in 1966, did it contribute to this narrowing of the Black-white infant mortality gap? And you can tell the Black infant mortality rate is falling much faster than the white infant mortality rate. And if you squint, it looks as though the Black infant mortality rate, the decline accelerates after 1966. All right. So what other things could explain that narrowing of the Black-white infant mortality gap? Well, like I said, lots of other stuff was going on at the same time. So Black Southerners were making significant economic progress. There were other government institutions, interventions, including community health centers. And then there's this recent work by Owen Thompson that shows that there was selective fertility going on during this time. By selective fertility, what I mean is it was the Blacks with the lowest levels of education who were cutting back on the number of births. So the quality of mothers among Blacks in the South was increasing during this period. Any one of these things could explain the narrowing of the Black-white infant mortality gap. All right, so we're going to just start with a really simple regression model. We've got the infant mortality rate in county C and year T as the dependent variable. The treatment is just whether any hospital in the county is certified. So the way to think about this is, did Black mothers in county C have access to an ostensibly desegregated hospital? We'll put in county fixed effects, but nothing else on the right-hand side. And obviously, we're leaving out year fixed effects. We're leaving out year fixed effects because Almond et al. Left out year fixed effects. So we're starting with Almond et al. Specification, more or less, all right? And then this paragraph, I guess it's not a paragraph, it's a sentence. This sentence is pretty much all I'm going to say about where the Medicare certification dates come from. But this required a year of data entry. So for every single hospital, we had to figure out, using these guide issues from the Journal of the American Hospital Association, we had to figure out when that hospital first started accepting Medicare funds. All right. And then finally, if there's no hospitals in County C, and there's on the order of about 1,000 counties, a little more, in the Deep South that just didn't have a hospital, then we determined access based on whether there was a certified hospital in a neighboring county. All right. So here it is. I promised you regression results. These are regression results. I want you to focus on the first column. So this is Black infant mortality. This is white infant mortality. The first column, there's no year fixed effects. There's no covariates. There are no county-specific linear trends. It's a really simple model that more or less mimics the model that Almond et al. Used. And what we find are these huge negative estimates. So 13 fewer deaths per 1,000 births, and the pre-treatment mean is 47.8. So it's a sizable reduction in the Black infant mortality rate. What's more is there's a sizable reduction in the white infant mortality rate. So 5 deaths per 1,000 births, as compared to a pre-treatment mean of about 24. All right, these estimates, this estimate, well, I should say this estimate, this is, let's focus on this estimate. This estimate is almost dead on what Almond et al. Found, okay? So this is very similar to the estimates that they, and I'll show you their estimates in a moment, but this is very similar to their estimates. All right, now, what happens when we take advantage of the extra variation? So in this table, what I'm showing you is how much variation there was by state in the number of Medicare eligible hospitals, so certified hospitals. And if you're Almond et al., you're just looking at Mississippi. And so there were 82 counties in Mississippi, and 57 of those 82 counties were certified in 1967. So that's within a year of the launching of the Medicare program. So most of the counties, and about 64% of the Black births were in these counties. Most of the counties had at least one Medicare certified hospital. So Almond et al. Were only, their variation, their identifying variation came from 25 counties that didn't have access to a Medicare certified hospital. And you'll see of those 25 counties, right, we go from, so 25 counties are holdout counties, if you will, to 74 in 1968, to 77 in 1969, and then by 1973, every county is served by at least one Medicare certified hospital. So when we expand the sample from Mississippi to all the states in the Deep South, we're able to take advantage of more identifying variation. So as an example, we get 7 extra counties in Alabama, 7 holdout counties in Alabama. We get 20 extra counties from Georgia. We get 10 extra counties from Louisiana, and we get 6 extra counties from South Carolina, right? So we more than double the amount of identifying variation that Almond et al. Had. All right, that allows us to put in year fixed effects in the regression. And I know this is simple, but obviously they belong in there. So what I'm going to show you next is estimates based on a more standard, two-way fixed effects model. And here they are. This was the estimated effect without the year fixed effects. And notice what happens when you put in the year fixed effects. It goes from negative and significant to positive and insignificant. Interestingly, for whites, it remains negative, but it's obviously statistically insignificant. And then we can add covariates and we can add county-specific linear trends, and it really doesn't change much. So pretty much no matter how you slice it, all you have to do is add those year fixed effects, and the all-in-all results just completely go away. That estimate, it's statistically insignificant, but it's precise enough to really reject the hypothesis that the federal campaign contributed to the narrowing of the black-white infant mortality gap. So if you use the lower bound of the 90% confidence interval, you can, so let me put it this way. If you use the lower bound of the 90% confidence interval, then certification, desegregation is associated with a 7% reduction in the black-white infant mortality gap. And that's not nearly enough to explain the reduction that we see. All right. Let me show you the event studies. Obviously, the event studies are what we want to see. There's more and more emphasis being placed on event studies as opposed to diff and diff estimates. But the event studies tell exactly the same story, right? So this is certification. You'll see that there's no pre-treatment trends. And in fact, there doesn't seem to be a trend in the post-treatment period either. This is for the black infant mortality rate. I mean, let me emphasize, there is really nothing here, right? This is for the black infant mortality rate with county-specific linear trends. Without county-specific linear trends. If you control for county-specific linear trends, you actually see this downward trend in the post-treatment period, but notice it's just a continuation of a downward trend in the pre-treatment period. This is for blacks, and this is what it looks like for whites. And again, if you put in the county-specific linear trends, you get this downward trend, but it's a continuation of the downward trend in the pre-treatment period. So the bottom line here is it really doesn't look as though desegregation had any effect whatsoever on the black infant mortality rate relative to the white infant mortality rate. All right, now, remember, Allman et al. Were interested not in the infant mortality rate, they were interested in the post-neonatal mortality rate. And the post-neonatal mortality rate is actually falling a little faster than the infant mortality rate during this period. What they're arguing is that hospitals during this time were well equipped to deal with the sorts of illnesses that babies after their first month of life, illnesses, so things that killed babies after their first month of life. So things like pneumonia, influenza, and diarrhea. And so what I'm showing you here is the mortality rate for infants, blacks versus whites, due to pneumonia and influenza. And you'll see it's declining rapidly during this period. And then here's the mortality rate due to diarrhea, black versus white. And again, it's declining rapidly during this period. So what we're going to do next is we're going to show you estimates for the black post-neonatal mortality rate, and then estimates for pneumonia, influenza, and diarrhea. And you'll see just right across the board, we get absolutely nothing. And again, This is evidence that the hospital desegregation campaign was ineffective, at least in the short run. All right. This wouldn't be an economics paper if I didn't show you a bunch of robustness checks. So we can control for the number of counties, bordering counties that had access to a certified hospital, and that doesn't change our estimates. We can drop the counties that had no hospital, and that doesn't really change our estimates. We include state by year fixed effects. That doesn't change the estimate. We can show you unweighted regressions, and that doesn't change the estimate either. We can also use alternative treatment definitions. So up till now, what I've been showing you is treatment is based on whether a single hospital in the county was decertified. I'm sorry, I keep on saying decertified. Whether a single hospital in the county was desegregated, but we actually have information on the number of beds in each hospital. So instead of asking whether any hospital was certified as Medicare eligible, we can ask whether 25% of the beds belong to hospitals that were certified, and we don't get a different result. Or whether 50% of the beds belong to a hospital that was certified, and we don't get a different result. We also played around with a 75% bed threshold. It really doesn't seem to make a difference where we put the threshold. Certification doesn't seem to have an effect. Now, you might think that hospitals that were certified in 1967 would look different than hospitals that were certified later. And so we can split it up based on whether treatment occurred in 1967. Remember, a majority of the hospitals were certified in 1966 and 1967 versus whether certification took place later. And again, there just doesn't seem to be any difference. No matter when the hospital, no matter when access to a certified hospital occurred, there doesn't seem to be any effect whatsoever on the Black infant mortality rate. And then finally, what we can do is we can take advantage of the fact that different states implemented Medicaid in different years during this period. And so what we want to do is we want to interact certification, so access to a certified hospital, with the availability of Medicaid. And the way you want to think of this coefficient is not only do Black mothers in the county have access to a certified hospital, but what's more, if they are poor, then Medicaid will pay for their receipt of care. So it'll pay for their treatment. And even there doesn't seem to be an effect. So getting access to a desegregated hospital and having the government pay for your treatment, right, pay all of your costs, doesn't have an effect on the Black-white infant mortality gap.
Daniel, can I ask a question?
Yeah, please.
Okay, I am Juan Angel. Did you try with the dependent variable the rates, not just the level, just the rates, because your dependent variable is the level, no? It has
It's the rate.
It's the rate.
It's the rate.
No, but is the one we can see in the graph? No, you can. Is the change in that? But this is what you are. Is your dependent variable is this variable, isn't it?
Right. It's the infant mortality per 1,000 live births.
Okay, but as you can see, there is a large trend here, at least in the black one. So
yeah, absolutely.
What I am saying is just instead of having or taking this as the dependent variable, why you don't take the first difference, where we say the change?
Yeah, so by me go back to, yeah.
variance.
Let me go back to the regression equation. So notice that we've got county fixed effects here. So we're not first differencing, we're differencing from the mean, right? We're demeaning, right, as opposed to first differencing.
Yeah.
It's the equivalent. You'll get exactly the same thing. You'll get.
You say when you use the trend, the time variable, maybe in that case, it's not statistically significant, this theta parameter?
I didn't get the second question. I'm sorry. Could you repeat that?
The second question is, when you introduce the time variable as dependent, you know what I mean? What is going on with the theta parameters?
Oh, they're highly significant. I actually don't have a slide that shows you their coefficients, but they're capturing all of, they're of course capturing, hold on, where are we? They're capturing all of this.
Yeah, the trend.
Yeah, they're capturing the trend. Yeah.
No, because maybe you might have large standard deviation, and that is why you are not getting statistically significant. So
this is exactly, I agree. This is exactly the issue, right? So the reason, let me hold on, where am I? Yeah. Let me go ahead just to,
go ahead.
Very important point. So let me, I'm going to answer your point right now here. Now,
Thanks.
These are the trends for each of the 5 states separately, okay?
Okay.
And I want you to notice that the steepest trend is actually for South Carolina, but Mississippi looks very much like these other states. Now, the issue here is, I'm trying to think where I can best make this point. I'm going to skip ahead a couple of slides, okay? Here are Almond et al.'s estimates. And remember, Almond et al. Are only looking at Mississippi, right? And you'll notice that without the year fixed effects, so there's no year fixed effects for Almond et al. But without those year fixed effects, the coefficient estimates are reasonably precise. They're all significant. Now, when you put in the year fixed effects, right, the identifying variation is only coming off of these holdout counties, and you'll notice that the standard errors blow up. So when you're only looking at Mississippi, right, power is, you don't really have enough power to distinguish between the secular trend and the effective treatment. But now let me go back to our estimates when we're looking at all 5 states. When we're looking at all 5 states, we can really distinguish the secular trend from the effective treatment. I want you to notice the size of the standard errors. These estimates, right, when we're using all 5 states and including the year fixed effects, these estimates are very precise. So you might the whole issue is, do we have enough power? And I think the answer is the size of the standard error suggests that we very much do. It's very clear that we have enough power to distinguish between the trend and treatment. Does that answer your question a little better?
Yeah, I think so.
Okay.
At least you had done something, trying to find out. Okay. Yeah.
Now, I didn't show you the coefficients on the year fixed effects, but they're soaking all of this up, right? They're capturing what used to be captured by the Medicare variable.
Yeah.
So I guarantee you they're big and they're negative and they're significant. But I didn't bother to show you them. And then going back to your original question, the county fixed effects mean that we're just we're mean differencing. We're not first differencing, but mean differencing and first differencing give you almost exactly the same result. All right. So now,
thanks.
I actually need to sort of wrap things up. So we went through all the robustness checks. I wanted to convince you that the trends in Mississippi look very much like the trends in the other states. And then if you look at the event studies, here's Alabama, here's Georgia, here's Louisiana, here's Mississippi. There's no evidence in any single state that that certification had an effect. But I do want to point out, and this goes to your point, that the standard errors are much larger when we look at one state at a time. Of course, right?
Right.
All right. Oh, and then notice the South Carolina pre-trend is South Carolina had the largest drop over the period under study, and you see that the pre-trend is very much the pre-trend is a real problem in South Carolina. So you've got this decrease in the post-treatment period, but it clearly begins before treatment. All right. I really want to show you what Almond et al. Did and what explains why our results are so different from theirs. So I've got Marcelo. Do I have about 5 minutes? Is that okay? Marcelo?
Unless, unless I am I'm the tipping voter, fine with me. Yes. Yeah, go for it.
5 minutes, and then I'll stop gabbing. Okay. So the first two columns show you Almond et al.'s exact estimates, and if you'll notice, they're estimating it looks like an event study, but the pre-treatment period is all grouped together, right? They don't dummy out the pre-treatment period. And here are like I said, these really large negative estimates, right? All of them are statistically significant. This is for the Black post-neonatal mortality rate. Now, we can replicate this is just for Mississippi. We can replicate the results very closely, okay? We don't have exactly their controls, and there's a few other differences, but basically we're nailing every one of their coefficients, okay? So this is our replication of Almond et al. This is without controls, then we add our controls, and it doesn't change very much. And then look what happens when you put in the year fixed effects. It just goes away. There's even for Mississippi, even using Almond et al.'s exact specification, there's nothing here. Now this is for Black post-neonatal mortality, right? A falsification test is to look at white post-neonatal mortality. Here are Almond et al.'s results, and then here are our estimates, right? When you put in the county-specific linear trends, you're actually getting negative estimates for whites that are comparable in magnitude to the negative estimates we found for Blacks. They're almost exactly the same size for whites and Blacks. So it really suggests that the campaign was ineffective. Now, Almond et al., we've been in touch with, with 2 out of the 3 authors. Kerwin is actually good friends with Michael Greenstone, and they are they're very adamant that their estimates are correct. They're adamant that I don't quite understand the rationale, but they don't think that the year fixed effects belong in the regression. I guess, what else can they say? But they really like this figure in their paper. So what they show here is it's a really a more traditional event study. So treatment is in year 0, and they're showing post-neonatal mortality rates due to pneumonia, influenza, and diarrhea in Mississippi. And they show, no pre-treatment trend, and then here's treatment, and then it falls like a rock, right? And they think that this figure is fantastic, right? This is the figure that proves that the hospital desegregation campaign was incredibly effective. Well, look what happens when you add year fixed effects to this figure. It just goes away. There's no evidence, even in Mississippi, that desegregation reduced post-neonatal mortality for Black infants. All right. Oh, I'm sorry. This is the dependent variable here is the Black-white difference. So there's no evidence that it affected the gap. I'm going to skip all of this. I'm going to skip the conclusion. I've got 1 minute to conclude. All right. Our identification strategy precludes us from looking at the long-run effects of desegregation, right? But at least in the short run, it's important to remember that desegregation met with fierce resistance. 214 hospitals refused to integrate their facilities. Hospitals that were certified flouted the Title VI guidelines. Black patients were really understandably reluctant to seek care at hospitals that had for generations segregated them or excluded them altogether, right? It's also important to note that the federal investigators, the OEHO investigators, they weren't asked to address structural barriers that prevented minority patients from accessing healthcare, right? And there's nothing they could do about deeply held racial prejudices. All they could do was force hospitals to admit Black patients. That was it. So the GAO report that I talked about earlier said that hospital desegregation eliminated overt discrimination, all right? The way I want you to think of our results is that they provide evidence that eliminating overt discrimination just simply isn't enough, right? That more subtle forms of discrimination ensured that Black infants were not receiving the same care as their white counterparts, at least in the 4 or 5 years that we can observe. I don't know what the long-run effects of desegregation are, and our identification strategy doesn't allow us to get at the long-run effects. But if you're interested in estimating the long-run effects, I think what our study says is you need to be very cognizant of the fact that the secular trends, controlling for the secular trends, accounting for the secular trends is genuinely important, right? If you don't have a well-identified natural experiment and you don't account for the secular trends, you're not going to be able to get either the short run or the long run effects of desegregation. All right, that's it. Thank you for your patience. I'm sorry I went over time.
Any questions?
Thank you. Any questions?
Yes, I have one question. Would it be would it be interesting to compare these trends with the trends that happen in the North with Black people?
Yeah, so this is a very interesting point, right? Much of Almondadal's paper does exactly that. And it's absolutely true that Black infant mortality was falling faster in the South, and especially the Deep South, than it was in the North during this period. But I think my point would be, it's an interesting comparison, but it's not at all clear what's driving those two trends. Blacks in the South were making economic progress, more economic progress than they were in the North during this period. There were targeted federal programs and state and local programs as well, targeted at, in the South, more so than the North, targeted at improving health outcomes for Blacks. So I think that comparison, I think that's an important comparison to make, but I'm not exactly sure how to leverage it to get the causal effects of desegregation.
Okay, thank you.
I think that's where we have to go. So Andrew Goodman Bacon, he had the same question, exactly the same question as your question. And remember, Andrew Goodman Bacon has a horse in the race. Do you know that expression? He really cares about this outcome because he has a paper in the JPE that shows that the Medicaid program was effective. And what's more is it shows that the Medicaid program was effective, not just in the South, effective at reducing Black infant mortality, not just in the South, but in the North as well. And so he's very interested in this North-South comparison. And I don't know if you recall, but this estimate, where were we? This estimate here, this negative, this small, right, insignificant estimate, that is directly contrary to what Andrew Goodman Bacon is finding in his JPE piece, right? It suggests that maybe the Medicaid program was ineffective in the South. I can tell you that Andrew Goodman Bacon has our data, and we've been sort of going back and forth with him. We've been sharing data and programs. We're pretty sure that he's one of our referees.
Thank you.
Sounds a little incestuous when you share your data with referees.
Okay, any more question? Or Marcello, try to lead
a quick point.
The presentation.
Hey guys, I really appreciate you. I really appreciate the chance to be able to present the results. Thank you for your comments. Thanks for letting me go over time. And I don't know, I look forward to seeing you in person, you know, after this whole COVID thing is settled.
Okay. Marcello, can you say something or any more question? No? No more questions?
Yeah, I'll follow up with office hours with Dan right away. So I'll keep it secret for him. Unless you have an overriding desire to listen to my question.
Oh, I see what you're saying. Yeah, so I'm happy to meet with anyone, and if it's not immediately after this talk, we can set up a meeting later in the day or even tomorrow. I actually have to teach today, of all things.
Okay.
So,
okay.
Teaching doesn't mean I have to leave my house.
Thank you so much for your presentation, and I enjoy a lot. And I think we are going to open our micro, and you are going to get an applause from us. And thank you very much, Guy. Can you open your micro and give a big applause for Daniel? Come on, guys.
Hello.